Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about terminology of skin lesions. We have two types of skin lesions, primary lesions and secondary lesions. Primary lesions include macule, patch, papule, plaque, nodule, cyst, vesicle, pustule, ulcer, wheal, telangiectasia, burrow, and comedo. And secondary lesions include scale, crust, oozing, lichenification, induration, fissure, and atrophy. The skin lesions result from alterations in one or more of the skin's structural components. For clinical diagnostic purpose, we try to envision what pathological changes are associated with each clinical lesion. Note: scale, lichenification, vesicles, bulla, pustules, and crusts present epidermal alteration, whereas erythema, red in light skin, purple or dark brown in darker skin, purpura and induration reflect change in their dermis. Skin lesions, as we can see here, we can see skin lesion, we can see vitiligo here. Vitiligo, the lesion of vitiligo is called macule. Vitiligo is a flat skin lesion, is recognizable because its color differs from that of their surrounding normal skin. The most common color changes are white, hypopigmented, brown, black, hyperpigmented, and red red, purple, erythematous, and purpuric. As we can see here, we can see the macule of vitiligo in this diagram, and we can see also the plaque of vitiligo, the macule of vitiligo in this photo. B. Tinea corporis. In tinea corporis, the lesions is called patch, a macule with some surface change, either slight scale or fine wrinkling. As we can see in this diagram, we can see patch in tinea corporis. In this photo also we can see the patch of tinea corporis. We have the lesion has slightly scaling and wrinkling. And C. Flat warts. In flat warts, the lesions is called papule. In papule is small elevated skin lesions below 0.5 centimeter in diameter. As we can see here, we can see papules in flat wart, and these are elevated skin lesions with the size of below 0.5 centimeter in diameter. And D. Breast carcinoma or plaque. In breast carcinoma, we have an elevated or plateau-like lesion more than 0.5 centimeter in diameter, but without a substantial depth. As we said, in breast carcinoma, we have plaque. As we can see in this diagram, we can see a plaque, and also we can see a plaque in breast carcinoma. As we said, it's without substantial depth. Here we can see their scar, the skin scars. In skin scars, we call the skin scars nodules. Nodules are elevated marble-like lesions in size more than 0.5 centimeter in both diameter and depth. In scar, the diameter and depth must be more than 0.5 centimeter. As we can see here, we can see skin scars in this diagram. Also, we can see skin scars in this photo, and the diameter and the depth of skin scars must be more than 0.5 centimeter in diameter. And F. Epidermal inclusion. In epidermal inclusion, the lesion is called cyst. Cysts are nodules filled with expressible material that is either liquid or semi-solid. As we can see here, we can see cyst in this photo, and in this diagram we can see also cyst. Cyst, as we said, we can see in epidermal inclusions. And G, herpes simplex vesicles. In herpes simplex we have vesicles, and in bullous pemphigoid we have bulla. Blisters are filled with clear fluid. Vesicles are below 0.5 centimeter in diameter, and bulla are more than 0.5 centimeter in diameter. As we can see here we have vesicles in herpes simplex, and here we have the bulla in bullous pemphigoid. The difference between the blister and bulla is in size. As we said, blisters are filled with clear fluid, and vesicles are below 0.5 centimeter in diameter, and bulla are more than 0.5 centimeter in diameter. And acne. In acne, the diagnosis here is acne, and the lesions of acne is called pustules. In pustules, vesicles filled with cloudy or purulent fluid. As we can see here, the lesions is filled with cloudy or purulent fluid. We call it pustules. As we can see here also, we can see the pus in there collected in the hair follicle or in sebaceous gland. And J, chronic herpes simplex. In chronic herpes simplex we have crust. Crust is liquid debris, example serum, blood or pus that has dried on the surface of the skin. As we can see here, we have crust and oozing in herpes simplex virus. Here we can see oozing and crust in this diagram. Scaling and K, scale, psoriasis. The diagnosis is psoriasis, and the lesion is called scale. Visibly thickened stratum corneum. Scales are dry and usually whitish. These features help to distinguish scales from crust, which are often moist and usually yellowish brown or red. As we can see here, we can see the crust with a slightly scaled white scaling or silvery scaling. In psoriasis we can see with the erythematous base. L, atopic dermatitis. The diagnosis here is atopic dermatitis. We called it lichenification. The presentation in atopic dermatitis is called lichenification. Epidermal thickening characterized by visible and palpable thickening of the skin with accentuated skin markings. As we can see here, we can see accentuated skin markings, and here we can see also epidermal thickening, which in palpation we can feel it easily. And the presentation is called lichenification. And M, we have localized scleroderma or morphea. In localized scleroderma or morphea we have induration. As we can see here, we can see induration in the patient with a systemic scleroderma. We can see it here also. In scleroderma we have induration, dermal thickening resulting in the skin that feels thicker and firmer than normal. As we can see here, we can see thickening of the skin, and this is filled because of the deposition of the fibers in the skin. The skin structure is we can feel a hard. We can see the firm and thicker and firm skin in palpation because of the deposition of fibers in their skin. As we can see here, we can see the deposition of fibers in the skin. Okay, and in hand dermatitis we can see fissures. A fissure is a thin linear tear in the epidermis. A thin linear tear in the epidermis. As we can see here, we can see fissures in the skin of these patients with eczema. Okay, or hand dermatitis. We can see the fissure also in this diagram. And pemphigus vulgaris, we can see erosions in pemphigus vulgaris. And erosion is limited in depth, confined to loss of the epidermis and superficial dermis. As we can see here, we can see erosions. Okay, erosions here, we can see erosions also. And basal cell carcinoma. In basal cell carcinoma, we have usually ulcer. An ulcer is a deep defect devoid of epidermis as well as part of all of the dermis. As we can see here, we can see ulcer here, and we have ulcers in this patient with the diagnosis of BCC or basal cell carcinoma. And Q, lichen sclerosus and atrophicus. We have atrophy. As we can see here, we have atrophy in lichen sclerosus or atrophicus. We can see atrophy here in this patient. The patient has a lichen sclerosus and atrophicus. Loss of skin tissue with epidermal atrophy. The surface appears thin and wrinkled. Atrophy of the much thicker dermal layer results in a clinically detectable depression in the skin. In palpation, we can feel the depression of their skin. Urticaria or wheal, a papule or plaque or dermal edema. Wheals or hives often have central pallor and irregular borders. Here we have urticaria or wheal with a central pallor or and irregular border. Here we can see urticaria or wheal and urticaria. Urticaria and the presentation we call it wheal. We can see the central pallor in these lesions and irregular border. And as sun damage or aging telangiectasia, the presentation is called telangiectasia. We can see telangiectasia in this photo, and in this diagram the telangiectasia is shown. Telangiectasia, superficial blood vessels enlarged sufficiently to be clinically visible. The superficial skin vessels is enlarged and it's visible on the surface of the skin. T. Scabies. We have burrow in scabies, serpiginous tunnel or streak or arrow caused by the burrowing mite. As we can see here, we can see burrowing mite and beneath the skin, under the skin, and the mite itself and the mite's eggs under the skin. We can see here the burrowing of the mite. And acne, comedo. We have comedo in acne. In plural, it calls comedones. The non-inflammatory lesions of acne that result from keratin impaction in the outlet of the pilosebaceous canal. As we can see here, we can see the impaction of the pilosebaceous canal with keratin, and we call it comedones. Here we can see also comedones, and this is due to the impaction of the pilosebaceous channel with keratin. Okay, clinico-pathologic correlations. We are going to talk about skin component, pathologic alterations, and clinical manifestation. In epidermis, in epidermis, we have stratum corneum, subcorneal epidermis, and melanocytes. In stratum corneum, pathologic alteration, hyperkeratosis, and clinical manifestation is a scale. In hyperkeratosis, we have a scaling, and in subcorneal epidermis, we have hyperplasia and disruptive inflammatory change and dried serum blood. In hyperplasia, clinical manifestation can be lichenification and papules, plaques, and nodules. In disruptive inflammatory change in subcorneal epidermis, we can see vesicles, bulla, and pustules. But in dried serum blood on subcorneal epidermis, we can see crust. Melanocytes, we can see increased number of function or decreased number or function of melanocyte. And clinical manifestation in increased number or function of melanocytes is pigmented macules, papules, and nodules. But in decreased number of function of melanocytes, we have white spots. Dermis. In dermis, we have blood vessels, nerves, and connective tissue. In hyperplasia or inflammation in blood vessels, we can see macules, papules, and nodules. And in vasodilation of blood vessels, we can see erythema. And in hemorrhage of blood vessels, we can see purpura. And in vasodilation with edema, we can see wheals. In nerves, we can see hyperplasia. In nerves, hyperplasia, clinical manifestation is papules and nodules. Connective tissue, we can see hyperplasia, loss of epidermis, and dermis. In connective tissue hyperplasia, we can see induration, papules, nodules, and plaques. And in loss of epidermis, we can see erosion. And in loss of epidermis and dermis in connective tissue, we can see ulceration. Dermal appendage, we have dermal appendage include pilosebaceous units, Swiss glass, and subcutaneous fat. In pilosebaceous units, we have pilosebaceous units, we have hyperplasia, atrophy, hyperplasia, or inflammation. In hyperplasia or pilosebaceous unit, we have hirsutism, and in atrophy or pilosebaceous unit, their clinical manifestation is alopecia. And in hyperplasia or inflammation or pilosebaceous unit, we have comedones, papules, nodules, and cysts. In sweet glands, we can see also hypersecretion, hyperplasia, or inflammation. In hypersecretion of sweet glands, we can see hyperhidrosis. And in hyperplasia or inflammation of sweet glands, we can see vesicles, papules, pustules, and cysts. In subcutaneous fat, we can see also hyperplasia or inflammation, and the presentation or clinical manifestation can be induration and nodules. Okay, this was a short explanation of skin lesions and presentation of different pathology on the skin lesions. Thank you for your attention.